go to the next set of complications. So I would want to present a case of, I think this is again a common thing of having a striae. So it could be microstriae, macrostriae. So this was an interesting patient which I had managed, a 24-year-old. It was already 3 weeks post-LASIK and a very positive girl who was really not bothered. She did notice a small change in vision compared to the other eye. So finally we both decided let us intervene, and this is how it went. So a lot of techniques in literature about managing flap striae. So first thing you need to understand that you need to treat any flap striae at the earliest to get the best results. And because the results are so good, I think even if it is a little changing on your higher order aberration, glare and halos, with a discussion with your patient, I think it would be a good idea to go ahead and treat it. So in this patient, we used all the 5 described techniques other than the PTK for releasing the striae. So this is how we went. So the first step always is to release the anchoring effect of your epithelium. So it's very important you remove the entire epithelium, and also very important to remove it at the edges, because the last thing you would want to have is an epithelial ingrowth. So remove it, and the second step would be to hydrate. So hydration is extremely important. Basically, you're swelling up your flap so that you're sort of flattening the striae. And the next thing is what Dr. Ravindra explained, the 2 technique of expander sponges. I think this is an excellent technique. These are probably the only instruments, because they're sort of firm, they're soft, they take the contour of your cornea and they do very well. So remember that you have to keep your visual axis clear. So always whenever you do a massage, make sure you're clearing up the visual axis. The 4th step we did in her was application of heat. Again, it's a well-defined technique in literature. We heated it up. I'll show you how we heated it up. And again, the same directions perpendicular to the striae. So go on massaging, and then we were still not happy. So I went ahead and took around 3 sutures. So other than the hinge, all the 3 sides, I took sutures to straighten out or iron out the striae. So this was end of surgery. You see a BCL in place because the whole epithelium is out, and 3 sutures. So this is how we heated up. There are a lot of methods which have been described. You can put it in hot water, but we just try to heat it up with a flame, and also manually checked the temperature before placing it onto the cornea. So pretty impressive results. This was at 1 week. The whole entire central 6 mm was totally free of striae. And a few tips I would surely want to give is always dilate your pupil, because however good your microscope is, you see nothing when you don't have a retroillumination. So this video beautifully shows nothing visible, and as soon as you make it retro, you beautifully see this striae. So always dilate your pupil, and the entire surgery is on retroillumination. Second thing is always remove your epithelium of the margins, because whenever you're using a sharp instrument to enter, this is the commonest reason why you have an epi ingrowth. So in this patient, we also used alcohol and also manually remove the entire 360-degree or other than the hinge, and that gave us a very good and a compact flap and no epi ingrowth. So I would say that is very important. And if you feel there are residual cells, you can always use alcohol before lifting up your flap. So that would be a important step. So this was a very good paper which showed this patient underwent corneal transplant post striae. So it shows that in 24 hours also it has been reported the epithelium can come and cover up your grooves between the striae. So unless you remove the epithelium, it's just impossible to get rid of it. So that's the most crucial step. And again, once you're done with that, good hypotonic solution swelling up of the flap makes it much easier. So here you see that even before I start massaging, just by applying the solution for a few minutes, the flap are looking a little less. That's just because of the hydration. Now, as I said, it's important. It's tough to get rid of all the striae if it's a long case, but at least make sure your central pupil area is perfect. So your idea is to anchor the flap. As Dr. Ravindra also mentioned earlier, there is a slippage if you just do it in one side. So first what we can do is anchor with your left instrument and massage your first half, and then anchor with your right instrument, and you can massage the left half. So basically you're trying to clear the visual axis, and if you're pushing the striae to the mid periphery, it should really not matter in your visual recovery. So that is another tip onto how to direct your instruments. And this, I think, is the best part. You see how ugly the striae looks, but just by putting by a drop of saline, how beautiful it looks. So again, it shows your entire manipulation should be based on your dry cornea, because only then you appreciate it. And it also goes on to say how important is your tears for your ocular surface. So how beautifully it can camouflage all the irregularities. So that is something any ocular surface treating person would love to see, how beautifully the irregularities disappear with moisture or water there. And the last challenge I always feel is you really don't have an end point. You are never happy end of the surgery. You always keep seeing striae. So it's just up to how patient you are and your patient are. So just keep massaging as long as both of you have an energy. I think this surgery went on for more than an hour. I just kept on massaging, but it's worth seeing the effect what you get. So I think patience is extremely important, and you really can't get rid of the striae on table. But you would see majority of the time, if it's managed with good patience, post-op you will have crystal clear corneas. So this patient did extremely well. So this was, I think, said it all. This was the higher order aberration, which was her only defect. Otherwise, she was 6 parts. So this was a pre-op higher order aberration, which matched the other eye higher order aberration after this procedure from 0.6 to 0.3. So patient was extremely happy. So those were a few tips on how I managed this case. So Dr. J.K. Reddy sir, any other things you follow differently? And one more thing is, I have never done a PTK on such patients. So what would your tips be on doing PTK in stubborn striae?